Hello, so my name is Dr. Charles. Today I'm going to be talking to you about what it's like to be an F1 and sort of the challenges that I've faced during my journey so far.
These traumas keep me awake at night. Trust these shoes, they stay on my mind. They stay on my mind.
So most of you have probably just sat your finals, or you've either just got your results that you finally become a doctor, which is something that you've been looking forward to become for so long. It's probably one of those moments in your life you're never going to forget due to the journey that you've come through, how long it's taken for you to get to this moment. It's one of those things you have to take a deep breath and really just cherish and appreciate because of all the hard work that's taken for you to get to this position. Now, some of you right now probably got your rotations as well. You've finally been accepted to your base unit. You know what rotations you're going to be going through F1. And for most of us, it's going to be a medical job, it's going to be a surgical job, and then there might be a specialty job as well, something like psychiatry or GP in the community. So for me, my rotations, my first one was acute medicine, second rotation was vascular surgery, and the third one was psychiatry. Now, each of these rotations, they bring their own different challenges and their own slight different skill sets that you have to know. One of the key things that you don't realize at first when you're applying for these jobs and you're leaving medical school is, regardless of what position you're doing, what you're bringing is the acute medicine aspect to every single placement. Even if you're part of the surgical team, you're not operating, you're not a surgeon, you're a medic who's posted onto the surgical team, and your position is to input this medical input to the surgical patients. So when you're part of acute medicine, you probably get more learning experiences because this is what they do day in, day out. They'll be able to help you and aid you at the job that you actually do a lot better. Whereas on the surgical job, you're expected maybe to think more outside the box past what the surgeons would immediately think. But still, there are some learning points in terms of how to manage surgical patients in specific, what kind of presentations happen in surgical patients. But it's not limited just to surgery, because even on a medical ward, you can send patients to go and have an operation, and some of them will be returned to your medical ward. Out of all my rotations, the one that I enjoyed the most was actually vascular surgery. Ward rounds will be short, straight to the point. You get through all of the patients and you go on and do your tasks. And it felt like every day you do your job, you get to the end of it, you feel like you've worked through your tasks. The annoying thing about a surgical rotation, I would say, is it sort of feels like they're very much focused on the surgical aspect of things, and maybe sometimes they lose aspect of the wider picture of things. In the team that I was working on, there was a bit of babying. They would have like a list of tasks that they needed doing. You'd go through the list after ward round and then go off and do the jobs, then meet up again in the midday to check the progress, and then meet again at the end. By the end, it was like, this is getting tedious. When I did acute medicine, we'd have a board meeting in the morning, we'll go through all the tasks that needed to happen, we'll go off, see the patient with the consultants, formulate further tasks, and then that's that for the day. The next time you discuss what was done and not done will probably be on the next day, or an informal chat on the ward with the consultant before they go home. The most challenging placement actually was psychiatry. I thought psychiatry was going to be a walk in the park, but I found myself having more responsibility than I ever had before. There was no real reg that was on the ward most of the time. It was me who was looking after about 20 patients. In comparison, in vascular, I'd probably look after about 6-7 patients. In medicine, probably look after about 7 patients. And in medicine, it was my first rotation. They were mostly medically fit patients as well, which made it even easier. In psychiatry, it's the added barrier of it being a hospital that was not near all the facilities. So you couldn't order any investigations at the mental health hospital. You had to liaise with the medical hospital that was far away, and this added extra processes of sending emails, asking requests, following up requests. There was an added secretarial element to it, and you're also managing all the medical emergencies of all of these patients. You have to assess, make a decision for yourself. Am I going to keep this patient in? Am I going to send them to hospital? And then your consultant is just there to tell them what's happened, and in extreme cases they might say, is this really appropriate? But mostly it's on you to act and decide, is it appropriate for me to keep this patient in, or am I going to send this patient for acute treatment? And put in mind, you can't put cannulas in the psychiatric hospital I was in. You can't really give them IV fluids. You can't give them IV medication. So it was really stressful. And the most challenging role as well was the psychiatry one, as it felt like you worked with the same team of people a lot more extensively than you did with the other teams, and you can find more people who are difficult to work with. And coming from a medical and a surgical rotation, I was more in the mindset of, I need to do things quickly and fast, because a surgical job, everything is moving at 100 miles an hour. Everything needs to be done then and then. There's no time to waste. Whereas in psychiatry, ward rounds are about 30 minutes a patient, if not 40. Everything is very slow. You spend 4 days out of the 5 days just seeing patients and 1 day doing jobs. So that was the biggest difference. Challenges that I found in all of the jobs that I worked was the working pressures. In medicine and surgery, you always have on-calls. On your on-calls, you're covering a lot of wards by yourself. So you could be covering something around 10 wards, as many as they deem fit in your hospital, and also depending on staffing pressures. And in these situations, you're literally prioritizing jobs, going to the most acute patients, seeing them. If you're seeing an acute patient, it's the case of calling your reg up and saying, I need help. You need to go see this patient because I'm seeing this one, and I can't get to them in time. And you also find yourself being put in situations which are quite compromising. You're meant to see patients that are sick to a certain level, and after a certain level, your regs are meant to take over. If your reg sometimes is overwhelmed, they'll call you and say, hey, can you go and start seeing this patient and assessing them and treating them because I'm tied up with this other patient that's really sick. So it's interesting. It's tough. First on-call shifts I did, honestly, I was ready to quit. It's stressful, but after a while, you get used to it. You get to know what you're meant to do, what you're not meant to do. You get to know what needs your attention very quickly, what doesn't. You get to know how to work with the nurses, how to tell them, to chill. You get to know what to go and respond to immediately and what can wait. That comes with time as you're refined. The second thing that I would say, sometimes expectations in a workplace can be extensively high. People can be expecting you to do a lot more than you can actually facilitate in your time. Don't feel underfulfilled if you're at a job and you're doing work and you can't complete all of the tasks. The work can never be finished. The other thing that you have to think about as an F1 is your portfolio. This is something that, ideally you want to keep at it throughout the whole year. There's going to be procedures you have to get done, clinical encounters where you take a history, examine, and you get feedback from either a reg or someone more senior, or teaching encounters with people like consultants. You have to keep a log of all of these things, and there's a certain threshold you have to do. You have to reflect on experiences that you have, and also attending teaching is another key component. One thing that I would say never to not do is there are certain surveys that have now been made mandatory. There's a GMC survey and a NET survey that you have to do. Make sure you do those on time when you get those emails. Don't delay. I nearly got in trouble for not completing those, so yeah. And there's also suggested training that your trust will make you do, like SIMS training or end of life care. Attend those. Save yourself the hassle, because when it comes to your ARCP, you want to make sure you've done all of these things and you're not stressing. It's not worth to get made to be an F1 for 2 years in a row because you couldn't just follow an easy portfolio. It's easier than medical school, so just get it done. Don't leave it till the last minute. My top tips for you to be a successful F1: know your acute managements inside out. Know your A to E. Know how to manage hypoglycemia. Know how to manage tachycardia. Just know how to manage all the most common acute presentations. And if you can't, know how to do your initial A to E assessment, stabilize the patient, know how to present your patient on the phone very coherently. And if you find something and you feel like you're out of your depth, and most likely this is going to be the case as an F1 when you're starting off, call for help. Call your seniors. They're expecting a call from you. Your reg will probably be chilling, just waiting to hear from you about what's going on, because they're not going to see any patient that's not very unwell unless you call for help and say you're overwhelmed. You're not going to get rewarded for being a hero. You will be punished for making mistakes because you thought you wanted to be a hero. So just call for help. When you're assessing a patient, always try to think of what's the worst thing that could possibly be happening here, and then after that, think about how likely is it this thing is happening, how can I rule it out, and then obviously make sure you rule out those very acute things that can end someone's life, and then obviously you can work backwards into less acute things. But your job is to stabilize the patient, make sure they're okay and they survive the night. Your job is not to make some miraculous diagnosis that's not going to affect their life in that night shift. Your job is to make sure the patient is safe and alive, and make sure you think of the most critical thing at that moment. Other top tips that you need to think about is increasing your circle of influence, especially if you're in a community role or whatever you're doing. So for me, for example, in a surgical role, I would make sure I was the one who woke up on most days and updated the surgical list that they had, which was brought into ward round, so my team would depend on me. That means sometimes if you make mistakes, have your own will, people are more likely to be like, oh, but that guy works hard and we know him. The second thing is never outshine the master. This usually rubs people off the wrong way. It's better off to just appear as if you're learning at the pace you're learning and you're not trying to outshine them. Learn how to word your suggestions in a nice way, but obviously if it's something that's pertaining patient safety and patient care, I'm not telling you not to voice your concerns. Voice your concerns, but know how to voice your concerns in a way which doesn't belittle or make people feel intimidated. As you know, it might not apparently show, but this will have effects on your relationship with these people and make your life harder in the long run. Other thing to talk about is locums. Be tactful about how you do your locums. You know, certain locums can come at escalated rates, because remember, the more you work, the more the tax man is waiting for you. Make sure you're tactical with your locums and pick ones which have got good escalated rates to save you from working extra hours and getting it all taxed away. In terms of holidays, be early, be the first one in. Especially if you're working at a trust where the organization is a little bit shaky, you want to be the first one to get your holidays in. Don't be out here waiting thinking you've got time. People will get their holidays in before you, and you will have to get random days here and there. Be the first one in, the first one out to get your holidays. Don't hesitate. But yeah, being an F1 is tough. Being an F1 is not nice. The first month will probably be the worst month of your life. It will be a role where you work the hardest, but you're the least paid, you're the least respected. The ward nurses, most don't respect you. They just see you as just an F1. So yeah, it's a humbling position, but you know, you're just there to play your position, and once you're done with F1 role, it's on to better places. Don't underestimate these community placements like psychiatry. I thought it was going to be a walk in the park, ended up being one of the hardest, most taxing roles I did. So yeah, take it easy. Make sure you make a good network of friends, make sure you have breaks. Yeah, just stay positive.
Who is that that's got your attention?